So, I am Mike Drew. I'm one of your classmates, and today I will be presenting on atypical sexual behaviors as evidenced in the paraphilic disorders from the DSM-5. And so, first, I wanted to just give a general overview of the DSM-5 section on the paraphilic disorders. And so, the DSM-5 has 8 of them. And these are not an exhaustive list by any means. These are just the most common or the most likely ones that you'll run into in sort of a clinical practice, and the ones that the general public is most likely to be familiar with. And so, the DSM-5, it's interesting how they organize the paraphilic disorders. There are actually 2 groups in their classification system. And so when you're looking at atypical sexual behaviors, you're looking at the difference from what you would look at as normophilic, what you would think of as typical normal sexual behavior that's focused on genitals. It's a heteronormative kind of view of sexuality, so focused on reproduction, genitals, pleasure. And what you get when you look at the atypical or paraphilic disorders is you can have, so you look at normophilic and anomalous relationships. And so you have anomalous activity preferences, activity being the key word here. And they break this down into courtship disorders, and these are things that might go awry in typical human courtship, mating, dating activities. And so this is where you find voyeuristic disorder, this is where you find exhibitionistic disorder, and this is where you find frauderistic disorder. Also interesting with all of these disorders is these are all non-consensual disorders. So voyeurism, exhibitionism, frauderism all involve a non-consenting person who is involved in these activities. They involve a crime being committed against a non-consenting individual. The second of the anomalous activity preferences is the alloagnic disorders. So here you have sexual masochism and sexual sadism. Alloagnic comes from the Greek word algos, meaning pain, and the Greek word lagneia, meaning lust. So pain derived from lust, lustful pain. So these non-normophilic activity preferences that are somehow now the object of the sexual desire. So you have preferred activities can include whipping, cutting, binding, strangling other people, and so the sexual desire is now directed towards these activities as opposed to maybe genital orgasm. And then the second group, so not the anomalous activity preferences, now you have anomalous target preferences. So now the drive or the sex, the goal of the sexual activity, the sexual urge is not an activity, but it is a target. And in this sense, you have one directed at other humans, and this is the paraphilic disorder. So you have individuals, you have adults who are sexually attracted to children, and you have 2 other disorders where the anomalous target is another object. So you have fetishistic disorder and you have transvestic disorder. So other targets can include children, corpses, amputees when you view this as a class of objects, non-human animals, horses, dogs, inanimate objects, shoes, high heels, boots, articles made of latex, leather. So it is the target of the sex drive itself that is now anomalous or non-normophilic. So what is a paraphilia according to the DSM? Well, a paraphilia is any intense and persistent sexual interest, other than sexual interest, in genital stimulation or preparatory fondling with phenotypically normal, physiologically mature, consenting human partners. So there's a lot to unpack there. So phenotypically normal means the expressed physiological characteristics. So you could see why this would cover amputees, as expressed earlier, as a class of objects, the loss of a certain normally phenotypically expressed appendage becomes the fetishized object in this paraphilic disorder. And physiologically mature, so in the terms of children, they are not yet physiologically mature, and so the sexual interest becomes fixated on the human before it is physiologically mature. Consenting human partners. So in terms of the courtship disorders with voyeurism, exhibitionism, frauderism, same with sexual sadism in the context where it's not a kink activity in an actual relationship involving consent, where that's something to be explored in the context of that relationship, in the sense of maybe a criminal or a forensic, psychiatric, or psychological case. They all would involve non-consensual activities, which is part of what makes it paraphilic, is because the sexual interest is gained from the non-consensual aspect of it. That's what makes it paraphilic. So, in order for it to be a disorder, the paraphilia also must cause distress and impairment to the individual. So, it must also cause harm, and the DSM also clarifies, or risk of harm, which is why you see with voyeurism, exhibitionism, frauderism, all of the ones that are non-consensual, even if they don't involve actual harm, because they involve risk of harm, because it's non-consensual, because it's criminal, they all entail risk of harm. So by definition, they become paraphilic disorders. So also important to note, the DSM-5 itself says, as many of these studies I'll go on to mention further in the course of this presentation, the presence of a paraphilia itself doesn't necessarily justify or require clinical intervention. They're completely healthy, normative, and can actually enhance and be part of normal, everyday, sex-positive relationships in adult, consensual, healthy relationships, be they heterosexual, homosexual, every type of relationship between, consenting adults can include paraphilias, and when they are shared and expressed with a partner, can enhance the satisfaction of the relationship, as studies have shown, and we'll go into that later. One important thing to note, when it comes to diagnosis, Fuss et al. In 2018 found that paraphilia seem to be overdiagnosed in men. And so there's a caution to be wary when diagnosing paraphilias that there might be an unconscious bias towards overdiagnosis in men. So it seems to be less pathologized in women. So there's a warning that this could be promoting gender stereotypes, and there's this notion of mental health practitioners and the DSM, the APA being kind of gatekeepers of culture and sexual morality and sexual mores. So are we the guardians of sexual morality? And if so, are we upholding gender biases in that? So it's something to be mindful of and conscious of. We go on to look at its prevalence in the general population, the prevalence of paraphilia. So I looked at a few studies, and so there are a few studies that use non-clinical samples. So these are drawn from the general population. And what they found was that 4 of the paraphilias, so we're looking at voyeurism, fetishism, and masochism, were neither rare nor unusual. And in fact, 45.6% of the sample wished to experience at least one paraphilia, so wished to. And 30, about 34% had engaged in at least one paraphilic behavior in the past. So roughly 34% of the population in that sample had engaged in at least one paraphilic behavior in the past. Voyeurism and fetishism are among the most popular paraphilias among men. Now we look at, as I was talking before, about paraphilias and sexual satisfaction. Research has shown that healthy people incorporate their paraphilic interests into their sex lives. And so if people are given the resources to do that, it can actually have a very positive effect on the relationship. We've been talking about cultivating an atmosphere of sex positivity in the counseling room with our clients, and trying to do that in the field. And I think being able to do this with regard to paraphilias, if we come across them in our clinical practice and being aware of them, was a great way to do that. So if we know of them, know about resources to help people out, and know it's out there, it's a great way to make sure we are clinically sound and well-rounded. Let's see. So participants in this study rarely reported any negative impact related to their interests, and that kind of fits with existing research that had shown that paraphilic interests do not really cause any negative psychological distress or impair relationships. So the presence of a paraphilia does not necessarily cause any adverse impact on people's mental health or relationships. That doesn't, mean that, because the paraphilic disorders are broad as a category, and most people's paraphilic interests are benign, a lot of them can be expressed healthfully in relationships. And in fact, according to the study, individuals who had a paraphilic interest and told their partner had higher levels of sexual satisfaction than those who had not told their partner or who did not have a partner. So, how about that? So there is confusion regarding the kind of category of the paraphilic disorders. So you always get into issues of culture when you kind of discuss sexual mores and sexual values and link them to mental health and mental disorders. So in the DSM, you kind of get to the cultural issues that are acknowledged itself with diagnosis. And one of the authors in the research I had gone over criticizes that. He says there's really no data on what constitutes normative sexual behaviors. So when you start talking about diagnosing atypical behaviors, there's not really much to run on. So what are we really doing, because we don't really have the data on what's normal to begin with? How can we diagnose what's abnormal? And that even if they're non-normative, it doesn't imply that these behaviors are pathological. And so if it's normative for one social group, but maybe not normative in another social group, that doesn't mean it's necessarily pathological, and that psychiatric diagnoses they shouldn't change from one social milieu to another or from one location to the next. They should be medical diagnoses, the same as diabetes or broken bone. So it should be culturally independent. It should be the same type of diagnostic criteria if you're diagnosing the flu in France as if you're diagnosing it in Istanbul, as if you're diagnosing it in Japan or America. You also have a very real issue where Fedorov takes this up in his article. Homosexuality is removed from the DSM in 1973 because there's lack of objective research pointing to it as a mental illness, and because it doesn't fit into the existing framework at that time of the psychiatric conceptualization of a mental disorder. So it's taken out of the DSM as a disorder. So with this category of paraphilic disorders, the lack of normative sexual behaviors, of there being an extensive background of what is normal, are we really going to have this around as a category for much longer, or is this sort of going to go the same way as homosexuality, or is it going to be expanded more? What are we going to find with this section come the next DSM-6 or DSM-5 tax revision? Who knows? So Fedoff does propose a new classification of paraphilia. And he's sort of aiming at more, he discusses kind of like how radiologists might approach diagnosing a broken bone if they're looking at imaging. And so he's talking more about whether or not the disorder involves an issue of consent or not, and what the age range of the target is, and whether, what the degree of dependence on that paraphilia to achieve normal sexual function. I guess normal sexual function being the ability to achieve orgasm, I'm not entirely sure. And then whether or not they have acted on that interest, so has it been a mere thought, or have they actually done that, acted in the real world? And is it intermittent, continuous, or in remission? So, there's an entirely different way to conceptualize a paraphilic disorder, courtesy of Fedoff. I did look up some pharmacological treatment options, courtesy of Psychiatric Times. Apologize, I'm looking at my references right here. It's a bit difficult to do these video things. So, there are pharmacological treatment options available for the paraphilic disorders. And so it's interesting to learn what they are. So, for mild to moderate examples of paraphilic disorders, they recommend beginning with psychotherapy. So CBT shows some great efficacy in kind of reducing the distress, anxiety, and co-occurring emotional disturbances that can be evidenced in these disorders. And so these very well may end up in our practices if somebody's referred for a paraphilic disorder. It does seem like a lot of the research I was reading seems that when they were talking about the clinical samples and non-clinical samples, a lot of the clinical samples were forensic criminal cases. A lot of it was done on child sex offenders, because pedophilic disorder is in the paraphilic disorders. And then looking at like frauderistic disorder, exhibitionism, like these are all things that are criminal as well. And so there are court-mandated treatment things, and it does seem like there's a lot of research done because of people's being wrapped up in the criminal justice system. But then looking at the non-clinical samples, like you have to look at, like they do talk about the bias of, how they have to find the sample selection types, website, telephone, things like that. But getting back to my point, so psychotherapy, mild to moderate cases of paraphilic disorders. When you look at the little bit more severe cases, moderate cases, SSRIs are great. We do know that it is well known that SSRIs can have sexual side effects. In the case of paraphilic disorders, those would actually be welcome. They can be used to induce dysfunction in libido, arousal, and orgasm, which could be useful in paraphilic disorders, keep people from acting on these urges, impulses, keep them from potentially committing further crimes if they are involved in the criminal justice system, keep them from engaging in things that are actually going to harm others or themselves. And then in severe cases, the use of anti-androgens, including synthetic steroidal analogs and gonadotropin-releasing analogs, which lower testosterone levels and aim to reduce sex drive and do away with paraphilic fantasies and urges. And these are injectable and long-acting as well. So I included a chart that shows, a kind of example of how physicians or maybe nurse practitioners could utilize something like this. I included a nice video from one of my favorite YouTubers, Dr. Lindsay Doe, a clinical sexologist. I'm a big fan of the Crash Course YouTube video series and all the Vlog Brothers videos, and she's part of the Crash Course YouTube family, so been following her for years, and here's a video she did a long time ago on paraphilic disorders. So hope you enjoy it. There's a lot to think about here, so I'd love to hear your thoughts and kind of the whole background on the paraphilic disorders. What you think about their classification status, and do they really fit the category of are they a mental disorder? Watch the video. Think about maybe some of the things you might encounter in your own practice. Have you heard of some of these things? Have you tried any of these things out in your own relationships? And what have you found? Are these things more normal than we've thought? Looking forward to seeing all of your videos, and thanks for watching mine.